Good afternoon, everybody, and welcome to another module of this wonderful myopia progression control certification program run by AIUS. So, at the outset, I would like to thank AIUS and Namrata Madam for giving the opportunity to all of us and to this myopia progression control program, so that our reach is bigger. We can have certification program, discuss among ourselves what are the newer modalities, how we can go about it. So today's module is about combination therapies and rebound whenever we stop a pharmacological agent. So basically, we will start with combination therapies, and then we will move on to a lecture by Dr. Mihir on rebound therapy. So I would introduce Dr. Janni. She is a young pediatric ophthalmologist from Arvind Eye Hospital, and she is the moderator for today. Dr. Tejaswini will be joining in short time, so then we can have her also. So right now I will ask Dr. Janani to take over.
Yes, sir. Good afternoon, sir. Thank you, Jitendra sir, for the opportunity to be a moderator for this session. So, wonderful modules have been going on. So, combination therapies and understanding rebound. So, myopia treatment has been evolved rapidly over the past decades from single modality approach to increased sophisticated combination of therapies. So today we have expert panelists and excellent presenters. Today we will explore science behind combination therapies and evidence around rebound. So I'll introduce the speaker, sir. So we have with us Dr. Muna Al-Kabi from UAE. So Dr. Nikesh, myopia specialist from LVPI. So Dr. Mihir Kotari, pediatric ophthalmologist and squint specialist from Mehta Eye Clinic, Mumbai. And then Dr. Ajinkya, he's from Prabha Eye Clinic, Bangalore.
So I think we will first start with the last. There was a video which we could not play in the last module. I will share the screen. We can discuss it. This particular modality right now is not available in our country, and so we had asked a foreign. Is the screen visible?
Yes, sir.
Yes, it's visible now.
Yeah. So this is the video, recorded video. Yeah, I'll just start it. Then we can take.
There we go. Okay, we're good. All right, I'll begin then. We're good. All right, well, thank you for inviting me to speak on this topic. My site, soft multifocal lenses are quite the thing now in the U.S. and have been very successful. And I'm looking forward to working with you on that topic, talking about it. This is a little resume of what I've been up to quite a bit here in Myopia. It's been a pleasure to be involved, to contribute, to see it grow, and we have a big task ahead of us. So I'm really excited to face that with you guys and gals, and to help as much as I can in your mission. Okay. So am I not controlling the screen or what? Oh, there we go. Okay, sorry. All right, so here's some pictures I have from the past. We've been together. Can you remember that one in Mumbai? And then just recently I was in Osaka, Japan, for a big ophthalmology event there that we did quite a bit of talking on myopia and introduced some things. And they were very excited to get more involved in that. So it's a thing that is a big deal. It was the first alert that we got to the fact that we had a problem. And with incidence now about 97% in South Korea, China over 90%, Taiwan, even Vietnam 85%. So it's a mission we're on now to try to do something about this and to create the environment for success. And I've had that pleasure to be able to do that in my travels and to participate in that and watch the growth in the field as we see practitioners taking this up and following through with it. This hip look very familiar to you. It's the chart we have here of the Brian Holden Institute. It's brought all of our attention to the fact that we have about half the world's population by 2050 is going to be nearsighted, and of that, 10% is going to be high myopia. And that's a critical thing because high myopia is where the high incidence occurs as far as pathologies. So we have to be, really cognizant of that and try to keep levels of myopia below that. And the only way you do that is you start early in a child's life, and then you aggressively apply myopia management techniques to keep it under control. I brought this in because I thought, here's something that's just an eye opener, no pun intended. We have 50% of the countries by the year 2050 are going to have 57% will have 50% incidence of myopia, and that includes India. So it's an amazing number to look at. This is a little bit of a chart to show you how I go through my thinking and what we do as we assess a patient. And we have these different interventions that we have, and it's growing. Here in the States, we've had the Stellus lens now for glasses that has been approved by the FDA. So you go through this and you look at the patient, the young patient in your office, and you have it in your mind what would be the best therapy and the best path forward for him or her. And I think it's really important for the doctor to be aggressive in that, to really suggest to the patient what they would, how they would begin that therapy. And of course, if it's not suitable for the patient, you need to come up with something else. But I think in the long run, most patients will try to do what the doctor feels is important. And I think as a part of your mission, you need to really get familiar with all these methods of myopia control and then apply them as necessary with each individual situation. So, as we move on, we're going to be talking more and more about that clinical decision making, in particular. So, get to the next slide. Doesn't seem to be advancing. All right, there we go. This is a picture of a soft contact lens, MySight, on the eye. So it's something I introduced. We don't get often a chance to look at the soft lenses on the eye anymore because we're doing such specialized work with sclerals and with ortho-K that we don't usually take pictures of those anymore. They become really common. These are two studies that came out of MySight. One of them is sponsored by Cooper Vision, the other one wasn't. And there is a difference of opinion here as far as the myopia management and control of the product. 30% versus 50 to 60% control with the Cooper Vision product. But I think Cooper Vision really answered that with their extensive studies that they've done, which we'll talk about. One other thing I'd like to focus on here is in the +2 myopic defocus. Now, this is on the low side with defocus, and usually we want to see more than that to be effective. So there's good news, bad news here. The lower defocus actually makes it easier for the patients to adapt to the lens. Peripheral vision's easier, but the 2 diopters defocus isn't enough, and we have an answer here that apparently it is. As 41% of the patients are showing no change after 3 years. Now, here an important thing to focus on here is that when they do these studies, of course, it's a consummate number from the entire participation in the study. Some patients do really well, some don't do as well. And so just taking this and looking at this from a different side, what happened to the other 6 patients? 4 out of 10 didn't change, but what happened to the other 6? And usually the answer is that some did okay and others did a lot worse. That's not the fault of the lens or the design. It just doesn't applicable to everybody. And so you need to do follow-up visits for your patients when you fit them. You just can't say, well, okay, I'm going to get 50% myopia control, and that's going to be it. It just doesn't happen that way. So you need to monitor very closely, and you may have to change therapy if it doesn't work. I have in my own practice with MySight, I do have patients that don't work with the MySight lens. It isn't effective enough. And then you can certainly add atropine to that, low-dose atropine, or you can take them and use something else. But the vast majority of patients are going to do pretty well, but then there's, those 3 out of 10 that won't, and they need your attention, so you don't want to miss those. And then, in optical interventions, this is 2019. I remember a class 3 device approval from the FDA. I was at the original Silver Springs meeting the FDA held on how to do myopia control, how to make it work. And this is a byproduct of that meeting that we had, because the FDA cleared the board here for action. And in 2019 they approved the MiSight lens, which we were in Europe at the time with an international meeting, and we applauded them for that. They attended that meeting. And then along in 2025, just last year in October, the Class 2 approval for the Stellus lens, which we won't talk much about that today. But these are two great new products we have available that can do a wonderful job of managing myopia for us. This is just an example of the Stellus versus MiSight. And here they're saying 59% in 2 years, after 2 years, and the Stellus at 71%. And again, take this with a grain of salt. There's a lot of variables here, and these are not controlled. Your patients will be not under controlled studies, so you need to really monitor what they're doing. I think if there's any take home here, it's follow-up is really, really important. Here's an example of what the one thing that's been well done by this Cooper Vision is they've run this 7-year study on the MiSight, which is really great. And they compared it in the study to the ProClear. At some point in the study, they had to take the patients out of the ProClear lenses because they were deteriorating vision too rapidly, and it was a choice of then, do I want to just prove a point, or do I want to save someone's vision? So actually, we have a great example. I'll show what that graph looks like a little bit later in the presentation. But here's an example again. 7 years is really a nice approach, and 50% control of myopia is a very good result. So again, let's emphasize the 41% no refractive change. And then we noticed that at a certain age, between the ages of 7 and 14, patients do deteriorate faster than when they're older. So you want to be able to check those as young patients and do something about it early on. So this requires being proactive. This requires seeing young patients in the office early on in childhood and being able to monitor them quite closely. There's also an avenue here to consider when you monitor these patients and they go through these growth periods that they have with the eyes that are changing quite a bit. There's a way then to introduce contact lenses. I mean, not if they're too young, that won't be an answer. But at some point in their life, here as a young patient, you can have them start to wear a lens like a MiSight lens, and this can make a huge difference in their life. My principle and practice has always been the freedom for my kids, my adolescents. So I don't want them to have to be restricted. Wearing glasses is not my idea of freedom. Especially these restrictive lenses that you have to use for myopia control. They require the precise centrations of the lenses, and they're not for active kids. We're going to have to struggle with this. This is if you have someone in sports or someone who wants to do more things than that, you're going to have to get them into something like a MiSight lens, and this is where we have a big avenue for our athletes and other more active patients. And also, it's just freedom. I mean, it's just wonderful. Think about it. You don't have to wear glasses. It's easy to wear. You wear it all day. You throw it away, and you wear a new one the next day. Very safe. And the patients, it's easier for them to get around in their environment. When they get old enough, don't do this right away, but when they're old enough, think actively about changing them off from, if you're using low-dose atropine or glasses. It's a great choice to go into the MiSight lens. So this is an example. The chart here shows the progression and how it's actually cutting that progression versus the ProClear, and how the fact is that it's 50% less progression. So it's remarkable in that respect. And again, we want to look back at the fact that with 50% control, you're going to reduce high myopia by 75%, depending on how early you start. So that's a huge bite into that huge number. Remember, we had that slide earlier on when we talked about the fact that we're going to see all these high myopes. Well, if we start doing this, we won't. And I worry about the medical system in general. How are we going to handle all these complications from high myopia if we don't get more active in this and reduce this to a level where these patients won't have the kinds of incidents that they can have? The other thing to think about is any level of myopia is not safe. Any low myope can develop a retinal detachment as well as a high myope can't. So you want to be very conscious of the fact that being aggressive and treating maybe with low dose atropine early on might be a good idea. So here's a chart that they did for the patients they took out of the ProClear and put into MiSight, and you can see how that curve, the upper curve there, changed dramatically from that point. It's a pretty remarkable finding they had here. Oh, sorry about that. So we're having a visual disturbance problem. It doesn't really happen with this lens. This is very easy lens to wear. It's not quite as comfortable as some of the other products they have, but it's a soft lens. They do remarkably adjust to it easily. It's good news for you if you're wanting to introduce a patient into contact lens therapy early on, because the lenses are extremely comfortable. So versus maybe if you're doing, when I think about orthoke, it's a whole different thing. It's worn at night, but there's more of an adjustment here. So the good news here is this is an easy adjustment for the patient. So the MySight lenses, one-day contact lenses, friendly and easy to use. You don't need to use any disinfection for them. You just throw them away at the end of the day. You replace them then daily. The other side of the coin here is that these lenses are rather expensive because they're daily throwaways. So you have to consider that too when you do this. And maybe this won't be a forever therapy for a patient. You might move into something else later on that patient can handle more financially wise. But this can be a great alternative for a while for you, or if you have patients that can actually afford it, just continue. Easy, it's great myopia control. I've had great success with it in my practice. We don't mind having them wear up to 10 hours a day, and that's something that they can do very easily in 6 days a week. And you commonly hear with myopia, the glasses or whatever you're using, you can give them a day off every once in a while. We haven't seen that. 6 out of 7 days is pretty good. We haven't seen a problem with that as far as controlling the myopia. So you give them a break. They can wear something else that other day and take a day off. Here's a little message on myopia. It's the eyeball's too long, it's happening too fast, and the eyeball's getting weaker from that process. So we want to be very cognizant of that. So it's the right thing to do, the smart thing to do, and the best thing to do. So good luck in your endeavor here, and good joy and mindfulness of how to take care of these kids, and enjoy this journey that you're on to help our kids with the myopia epidemic. Thank you.
Thank you so much, Kerry. It was really a wonderful.
Lenses was.
Thank you, sir. Thank you for insights on MySight. So we also have expert panelists here. Dr. Digvijay Singh, Dr. Rashina Bansal, Dr. Shwati, and Dr. Rajesh Prabhu, and Dr. Pavan. So can we have their comments on this MySight lenses from expert panelists today?
Yeah, Jitin, I think as was already discussed, the two things that we'll have to see with the Indian context would be the pricing and the ability to be able to use these lenses, in our sort of a climate, and also, the duration for which they'll have to be used. So I think, yeah, but it's something definitely that we look forward to get here and see.
So how difficult is it to adjust for alternate treatment and vision zone from Shwati ma'am?
I think none of us are really using MySight contact lenses. I sort of filled up this particular talk so that, at least in Indian context, we should be aware that these lenses are available. Obviously, it is difficult, as Dr. Digvijay rightly said, and we discussed this at length in the last module, that, with our climatic conditions, we are really, as pediatric ophthalmologists, we are really worried, about microbial keratitis and problems, especially with hygiene and topical climate, where we are worried that kids may have secondary infections or problems with these lenses. So maybe we can move on to this particular module on combination therapies. This was actually a video from last module. We were not able to play it in that module.
Thank you.
Dr. Tejaswini,
Yes.
yeah.
Yes. Thank you for your insight, sir. We'd like to call our next speaker for today, Dr. Nikesh Kangane, who is a senior optometrist and myopia specialist from LVPEI. He'll be speaking today about low-dose atropine and orthokeratology together as a combination treatment.
Yeah, can you hear me? So just to correct, I am a consultant optometrist, not ophthalmologist. So firstly, I would like to thank team AIOS and Dr. Jitendra for giving me this opportunity to talk on this platform. Today, I'm going to talk on this combination intervention specifically, which is low concentration atropine with orthokeratology lenses. So the flow of my presentation will be, I'll talk with, go through one case, then I'll touch upon ortho-K and then literature about combination intervention, and then take clinic message for us. So directly starting with the case, there is one case generally which we have seen, 9 years young child which was referred to us because of progressive myopia. So detailed examination was done, and then we looked for all the parameters which usually we assess in myopia clinic. So the child was started using glasses of 5 years, and for 4 years he was using glasses. So that's 9 years that the presenting age in our clinic. His spectacle power was -1 at the first visit, like first time when he started using. And in history, parental myopia, like both parents were moderately myopic. So we also look for other parameters which include about outdoor activity and near work. So near work, basically school and tuitions including gadgets, about 10 hours. Outdoor activity, he was a bit sporty, doing skating about 1 hour every day. Like we look for working range as well, how close he holds books and reading, writing things. Generally, he holds bit closer, around 20 centimeter. Sleep quality was good, around 9 to 10 hours. So refraction at presently, when he present, the refraction was about -3.5 diopter with -2 cylinder at 30 in right eye and -2.5 with -2 at 160 in respective eyes left eye. So cover test was also performed, which was distance for near and distance generally cover test, and then accommodative lag was also performed, which was within normal limit. So whenever we saw generally the refractive error about 0.50 diopter increment was there, and axial length is about 130 to 110 micron increment within 7 months it was there. Then again we also looked for peripheral diffraction, which we have done with open field autorefractor, so which indicate in specific temporal meridian 30 degree there was relative peripheral hyperopia in both the eyes. Then also and nasal meridian it was myopic and emmetropic in right eye. Biometry was also performed, which shows myopia is axial in nature. And as this patient was referred to us, before that only he was using atropine since 1 month. So just 1 month back, they have seen and they started on atropine because of progression. And probably for further assessment, they have referred to us. So this was we have seen at first line. So we asked to continue same atropine eye drops. And then we also motivate him to go out, maintain same outdoor activities, reducing gadgets, specifically take frequent breaks while doing any kind of near work, not to go closer or bend for reading, writing as well. So again, when he came to follow up after 3 months, usually that time the axial length changes were about 0.06 mm, about approx 60 microns. So that time we thought, oh, okay, in just 3 months, 0.60, which seems higher. So we have advised ortho-K option. So this was the lens fit post 1 month of trial. Generally he have ordered the lenses, and this was his photos with his lens, slit lamp photo, and this was corneal topography, mid-bond topography, which is there, which shows very good acceptable fit. And in this mid-bond, which shows about peripheral curve, which is having around 6 diopters to 7 diopters, creating relative peripheral myopic generally change. So now what all the options, if you see before and after starting the like ortho-K monotherapy, around again when we added on atropine, there was about 60 micron change in the axial length in just 3 months. And after adding ortho-K lenses, there was less changes, around in overall about 1.5 year to close to 2 years, about 150 microns. And then in left eye is about 160 micron changes, which is as compared to prior, it was less. So this case was well managed with ortho-K. Now talking about different myopia control options, what all options we have, starting from behavioral modification, then optical, we have different design of glasses, bifocal or progressive addition lenses, peripheral defocus glasses. We have different kind of contact lens as well. Rightly mentioned earlier, multifocal contact lens my side, but we don't have in India. We have different multifocal contact lens, ortho-K, EDOF. We have pharmacological interventions, atropine eye drops with 2 different concentration are now available in Indian context. Then we have combination. If one thing is not working, we add multiple, probably pharmacological as well as optical treatment. And if we are seeing severe myopes, probably the need of partial correction, which is also there. So today I'm going to talk about combination intervention, specifically atropine with orthokeratology lenses. So just to touch upon ortho-K, which is like a RGP lens, which is having 3 zone, central, base curve, peripheral, reverse, and peripheral curve. There are 3 zone: base curve, reverse curve, and peripheral curve. Now we got modern ortho-K as well, which is having multi-curve around 4 or 5 curves. So how it will work? It's whenever you put the lens, you will sleep. It will give negative pressure against the cornea, which flatten the central cornea, means there is relocation of the fluid to the mid peripheral zone. That reverse zone which we see usually elevate, and then it will create a ring pattern. So now this is how it will work. So if you talk about creating myopic defocus in this specific myopic children, whenever child or any individual wear these lenses, at first visit you can see this. Can you see my cursor? This is when he wear for about 4 hours. So there is central flattening as compared to periphery. When he wears for longer duration, about 8 hours, the thickness flattening will be increased. And when he use probably for 2 weeks kind of thing, then it will give maximum effect. Generally it's depend on the refractive error as well, and that's how it will create peripheral generally change the peripheral pattern, which create relative peripheral myopia as compared to center. So now we talk about literature in terms of combination intervention. So this is one paper which is coming out from our group as well. So which which is submitted in generally submitted, and revision is also submitted, minor revision which they got. So this was mainly talking about comparison and if generally talking about combination intervention. So when they have looked for combinations, when literature was searched, about 19 papers on ortho-K with atropine they have seen. So about 19, about 10 were retrospective studies, and rest of them were clinical trials. Out of that, 2 were prospective studies. So the take clinic message from the retrospective study, majorly the combination intervention works better as compared to monotherapy. So most of the times this ortho-K was given as a first line of treatment, and then they have added as atropine second. And among the studies, generally there is one study which was by Chen et al, which shows peripheral, both the combination as well as monotherapy, both were similar effect. So it was null effect. So take away from this slide is about monotherapy. The average generally progression which with monotherapy is about 200 microns to minimum, and about 400 microns maximum in a year. When we move to the combination, it was about 100 microns in a year to about 280 microns in a year. So when we look at a randomized clinical trial, which also similar trend, like combination is more effective than monotherapy. So again, take clinic message from this slide is about monotherapy about 160 micron to about 400 microns changes in a year. Then combination, when we move to combination, about 70 microns to 300 microns changes per year generally. And there is one study which also indicates like different concentration of atropine they have studied with ortho-K. So again, higher the concentration, relatively good the efficacy which they have seen in. And most of the studies which they have conducted is from the Chinese population and Japanese. Only 2 studies which were from Japanese population. And the refractive error which they include is about low myopia, which is less than -6, and again age group which they have include about 6 to 14 years. So what all proposed hypothesis they have indicated in that study. So how the lens and atropine is working, specifically when we give ortho-K, it's changing the refractive peripheral diffraction pattern, which creating relative peripheral myopic pattern. Second, it is changing on the contrast of the peripheral retina. It's changing the peripheral aberration profile, which creating positive or spherical aberration in the eye, reducing the accommodative lag in patients with ortho-K. When we talk about atropine, then it is a muscarinic receptor which binds and which inhibit the signals which go to the brain, generally negative signal which can trigger to increase, and again choroidal thickness which can increase as per Dr. Mastamura et al. So then if we talk, so is it for everyone? Should we give a combination or is there any protocol? So again, this is, as I have already mentioned, like our group has come up with this, where we started with, firstly, whenever we see progressive myops, first go with monotherapy, then monitor probably depending on progression rate, probably 6 months, 4 to 6 months kind of thing. If the changes which is more evident and more progressive, then you need to go for progressive, probably for combination. If it is still with that combination, again see after 6 months. Then if it is still more progressive or rapid progressive, then you can change your combination option. If it is a, when you are given monotherapy, if it is slow changes, slow progressor, then you can continue your monotherapy as is, and you can ask for follow-up after 6 months. If there is again change, if you are seeing probably in follow-ups is there is rapid changes, then again anytime you can switch to the combination. So the definition for fast progressor which they have categorized is more than 0.50 diopter change in refractive error and about 0.20 mm axial length per year. That's where they indicated progressive. Then current scenario, if I talk about the acceptance of combination intervention, there is a recent paper in 2020 which talk about global trend of combination acceptance, which shows about from 50% to 65% now practitioners are accepting combination. But we need to take in mind that combination is not a first line of treatment. So monotherapy is always a first line. So why combination is not a first line? So probably because of the complex management, which include probably the problem with the patient, like reducing visual performance with concentration of atropine, photophobia, or can reduce the contrast acuity of that patient. Cost may the barrier majorly in Indian context. Again, if we give multiple things at a time, then probably parents' attitude can change toward the practitioner. So should be only reserved for the combination only reserved for the fast progressor, which is having more than 0.50 diopter change along with or excellent change more than 0.20 mm in a year. So in a summary, combination of ortho-K and atropine was better, and which is most commonly investigated in the studies as compared to other studies. Then second, combination treatment is not the first line treatment and should be reserved only for fast progressor. Again, whenever we give generally high cost, increased management complexity, visual side effects, we need to monitor as well. And in lastly, more long-term clinical trial which are needed, understanding of mechanism required for make combination therapy well established approach in the field of myopia. So at then I would like to acknowledge LV Prasad Institute, Info Myopia Center, Dr. Pawan and Swapnil for this guidance and mentoring. Thank you.
Thank you for the sharing critical information about combination of low dose atropine and ortho-K fast progressors who are especially not getting controlled with just monotherapy. I request the expert panelists to opine about this, please.
I have one question to Nikesh.
Yes, sir.
So in the case example which you have told, like what factor did you consider to switch over to a combination therapy with the orthokeratology over the DIMS or any myopic lenses in this child?
So the case which I have presented.
Treatment, do you consider any specific factor to switch between the DIMS as well as orthokeratology?
No, you are talking about this specific case which I have presented.
Yeah,
So
generally, we want to combine a treatment, and my question is like,
yes,
how to
okay.
choose between DIMS or orthokeratology to be added along with low dose atropine?
Okay. So whenever we see first indication, probably we look for the like whatever risk assessment scores generally, peripheral diffraction, the amount of peripheral relative peripheral diffraction variation in term of center to periphery, which we can create with ortho K about 6-7 diopters if it is more. Firstly, then about child's regular activity, if he is more motivated for get rid of glasses or something, he is more sporty, then probably with contact lens option we opt. Generally, whenever we see peripheral relative peripheral hyperopia, we give the option of glasses as well as contact lens. But depending on the routine, generally we choose the option which one will be the better and suitable. Again, the compliance and that things will matter there.
So there's this lot of gray zone about, when to switch the therapy and when to combine the therapy. So how would you consider that instead, if there is a progression, would you want to switch to a different therapy or you would want to add on a new therapy to it?
So mostly if we are using anything, we are not going to switch at a first time. Sometimes now again the multiple things will comes in picture like age. So what age we are seeing? Is it like physiological growth spurt? Is it that triggering in that age specifically? Is it overcome that? Then we will add on combination definitely according to the routine and risk factors which I talk about lag. Then we talk about peripheral diffraction, Fourier status. According to that, we will add that. If that is also not working, then might be switching to the other intervention. That will be the better way.
Okay. So is
Mr.
there any
Nikesh,
way, we can say that, if this is the amount of progression which has been mitigated a bit as compared to before starting any intervention. So if there is no change in the rate of progression, would you still want to continue with the same therapy or you could still, consider switching the therapy?
No, if there is a progression, that's what first we need to document the progression, the amount of progression, whatever. And with that only we will monitor how is it controlled or it's still progressive. If it is still progressive, then adding on second thing, which is combination. That's what we follow.
Okay.
though Nikesh has given a big note to first
Yeah.
line of management, a combination therapy to be a first line of management. I just wanted to know from the
No,
other
no.
panelists.
I have said it's not a first line of management.
That's what
Monotherapy.
I wanted to hear it from the other panelists whether they have any specific criteria to start it as a first line of management. Have they prescribed
So,
a
yeah,
combination therapy as a first line of
as
management?
No, we generally don't unless, no, no, no.
no, the
Not as a
message,
first
I think
line.
the message for the general, the ophthalmologist and everybody is that it should be you should start with one line of therapy and add another. But there are certain circumstances where I have started combination right away, where I've seen the family history was a very high myopic. The parents were very concerned. They wanted to give it everything. So those are exceptions, not really the rule.
I have given the same thing I wanted to ask. That's the same thing. I have given for few patients who has a strong family history, both the parents myopic and the child presented with the high myopia very early in the age group. Say, for example, 7, 8 years, they're already -3, -4. Those are two circumstances where I have started as a combination therapy as the first line of management, and it's working well.
But as an exception, sir, I think generally the message to go across is that one should do one therapy and then
Very
build
rare
it.
indication,
Therapy at a time.
Yeah.
not as a
That's
usual,
a better idea.
very specific indication. Yeah.
Also, mainly because these. Yeah, go ahead. Go ahead, Rashid.
So I've had patients in my practice where basically on the first visit we give single vision glasses. Follow up on the first visit, I've explained them that this if it progresses, they may need further intervention, and then explain everything about low dose atropine, the defocus glasses. Next visit, if we see progression, and they generally opt in the clinic for the low dose atropine, and I've seen many parents coming back getting defocus glasses in addition to that by themselves because we have discussed about it. So in overall, I have seen that some patients over the counter, they are getting a combination therapy. Yeah, they are starting by themselves. They have access to Google. They read everything. They say, it's written combination works better. So why don't start it on the first go? So it's a big, still we have such a gray zone that how to counsel them further not to start the second treatment is again a big question mark.
I think what happens with combination therapy and why Dr. Digvijay is also so keen that we should start with one therapy as a rule, mainly because, if you start combination therapy, it becomes difficult to know which one is working.
That's the
And,
point.
these myopia management is going to be there for at least 8 to 10 years or at least for 6 years. If you start at 8 years of age, you will be continuing this for another 6 years. So you really need to have a backup. You really need to know what is working for this particular patient. So if you start a combination therapy, it is working. And most of the people who are into myopia do understand that after 3 or 4 years, whatever you are using, you need something to add on. I mean, whatever you use, it is not enough. Probably because the child sort of the environmental modification doesn't take place, or the child goes into growth spurt, or physiologically he is immune to the kind of treatment we are giving. Then it is very difficult to know. Right now, I think bulk of the data talks about two kind of therapies to be used together. I couldn't find out an article which has three therapies. But I don't see a day in future where, if we start doing like this, we may need three therapies, red light, orthoke, and atropine together. I don't know. I mean, that everybody
But-
can spool on their experience.
One must remember that all this is in addition to the first form of therapy, which is lifestyle changes. So I think,
Yes, yes.
in a
I
way,
go without saying.
to think of
I
it.
think
But
that way, I think that way we're all doing combination to start with. One is
Yeah,
lifestyle.
we are doing combination because baseline
There
is environmental
either
modification.
spectacle or atropine or whatever to start with. I think the one of the points that I want to also highlight is we initially assumed that orthokeratology, the acceptance is much lower, but only slowly we realized parents actually want to take full control of myopia management, and they feel that a child is with me when I insert the lens and then remove the lens. So we started to educate them, hey, there is something like this is available. If the child is feeling cosmetically, or maybe there is bullying in the school, or want to be spectacle free for any reason, there is this option. You want to try, the option is yours. Whenever we bring in the concept of contact lens, we ensure we tell them about this option upfront.
I think cost is one of the most important factors whenever we talk about ortho. At least in our practice, cost becomes a major issue. I mean, obviously, as you said, Dr. Pawan, that parents do want to take control. Most of the parents are very happy with a situation where the kid is glass free, because they won't be knowing much about what are the problems of contact lens. But mainly it is once you go into the cost range, then the interest sort of reduces, because cost is a huge hindrance even for glasses. And obviously, ortho is a slightly expensive modality of treatment.
Correct, correct. So we usually wait maybe 4 months to 6 months at least before we jump on to doing the combination treatment. Most of the times.
So which patients do you take as non-responders? Like how much progression would trigger your response towards combination therapy, and how much of axial length and how much of refraction?
So we say about 0.2 millimeters with monotherapy. Within 6 months to 8 months of time, if it's really rapid, in spite of giving monotherapy, more than 0.2 millimeters in 6 months, then we start to think, okay, this is really going close to 0.4 within a year. And then we look at that. Largely, I base it based on the axial length changes more than the spectacle power alone.
And do you give some leeway if you feel that this was probably one-off thing, maybe a growth spurt, and this won't come back?
Correct. Growth spurt, I think we'll keep that. And the child, if every time it's been stable and suddenly it jumped up, then we say, okay, what happened in the last 6 months? Did you do a lot of near work? Did you not go outdoors, or was there a growth spurt? We started now to get the height of the child as well. And we give that one benefit of doubt for 6 months. Everything is stable. Suddenly there is a jump. Let's wait 6 more months and take a call.
Dr. Pavan, when you consider the duration of the treatment of low-dose atropine to be 2 years in most of the studies, so do you really take 6 months into account to see a notable change in the axial length to decide for a combination therapy, or you want to wait for at least a year or so?
We will wait at least a year. 6 months, there is a hint that, okay, I'm going in that direction or not. So first time we give that benefit of doubt for either child being more indoor centric, did not follow the recommendations, compliance, or maybe growth spurt. And the repeated, the second visit, second follow-up also confirms that. Then we say, okay, maybe it's time for us to jump on, do something else. But definitely we go more conservative, not really aggressive in the plan.
Also, I would like to ask the experts and Pavan, like, would you like to escalate the dose of atropine, or you will jump to a combination therapy? Like you are on 0.01% once a day, whether you would increase it to twice a day, or whether you would escalate it to 0.05% first, or you would introduce another modality of treatment.
So, Dr. Jitani, what we do is, if I go with looking at the accommodation, we look at the peripheral refraction also. If there is a hyperopic defocus, for example, then maybe I want to start the spectacle modality. If it's more myopic defocus already sitting, then I'm going to maybe go in, jack up the dosage of the atropine from 0.01 to 0.05. If there is a more lag, then I would go with lag with esophoria. We go with the bifocal. So looking at these 2-3 parameters, we say, okay, do I now do combination or just increase the dosage? Again, dosage we've been doing only more recently with 0.05. We have only a handful of cases.
Dr. Rajesh, Dr. Swati, Dr. Rashina, and Digvijay, will you do it differently?
Yeah.
Not an issue for the parents. I would like to generally go for a combination therapy with the DIMS lenses. Sir. That is the criteria which I take into account. Because a lot of my children have come back with BD dosage with reading difficulty. And as Dr. Pavan clearly mentioned, 0.05, we have got only 3 or 4 patients, and that too for a very short follow-up. It's too early to comment about 0.05, but 0.01 BD dosage, we have got some problems with the children in reading.
And would you really do a peripheral refraction, or you would just tell them that, the glasses?
I don't do peripheral refraction. I straight away, if cost factor is not an issue, I straight away add a combination therapy. Yes.
Yeah, for our patients, the cost factor indeed comes into picture because most of our patients come from a very low socioeconomic background. So if atropine is working, but it's not slowing as enough as we would want it to be. So the rate of progression was something, say, for example, higher, and it has slowed down, but not as much as we want it to be. We'll definitely jump for the higher dose of atropine rather than adding a combination. Of course, if the patient can afford, that's a major factor with our setup, that if patients can afford, would rather have glasses, switch to glasses, than going for a higher therapy, higher concentration. So
Yeah,
that's
so same with me. I discuss both the things with the parents, and depending upon what they are comfortable, if they can afford, then I give a combination first with atropine with DIMS. If they are not able to afford, then I jump to the higher dose of low dose atropine.
I think both the therapies are working through different mechanisms. So basically, what I feel in that patient is probably the main mechanism, or what I think. So sometimes I would do a quick peripheral refraction to see what's wrong. But in most cases, I go back again, what I was emphasizing, to the lifestyle changes. I realize that they have not changed. They're still reading all day. They'll be reading, for continuous hours, or they're still on their smaller screens. They're still indoors. So I first also always re-emphasize on that, and then give a higher step up on the medication before I add the combination.
Thank you for the discussion to clarify when one should switch to a combination therapy. Now I request Dr. Ajinkya Deshmukh to speak on low-dose atropine and myopia control glasses as a combination therapy. He's from Prabha Eye Clinic, Bangalore.
Thank you. Is my screen visible?
Yes.
Just a minute. Yeah. At the outset, I would like to thank Dr. Jitendra Jethani and AIOS for this opportunity to present the interim results of our clinical trial, the efficacy of Myocare lenses in comparison to low-dose atropine in preventing myopia progression, which we conducted at Prabha Clinic and Research Center, Bangalore. Just a minute. Just move the bar up. Yeah, so the study was conducted in association with Zeiss Vision Care India. The objectives of the study was to study the efficacy of Myocare lenses in controlling the progression of myopia, and also to compare the same with that of 0.01% atropine eye drops alone, or as a combination therapy with Myocare glasses with night dosage of 0.01% atropine for those who showed unsatisfactory response to the HS dosage alone in mild to moderate myopes. So it was a prospective, interventional, non-randomized, comparative clinical trial. The scientific and ethical committee approvals were obtained. The written informed consent was obtained from the parents of the children who were recruited. So the sample size was calculated. Total 150 patients were recruited, 50 each in treatment naive groups. Group 1 was prescribed with night dosage of 0.01% atropine, and group 2 was given Myocare lenses. Group 3 and 4 were those who were non-responders to the night dosage of low-dose atropine. Group 3 was given increased dosage of from HS to BD, whereas in group 4, we added Myocare lenses on top of the HS dosage of atropine. So we included the patients who showed the documented myopia progression of more than 0.5 diopters within 6 months. The objective cycloplegic spherical equivalent error was minus 0.75 to minus 6 diopters. The astigmatism was less than or equal to 2.5 diopters, and an anisometropia of less than or equal to 1.5 diopters. The best corrected visual acuity of 0 logmar or better in both eyes. And the age group, which was taken into consideration, was 6 to 15 years of age. Patients with the history of ocular trauma or intraocular surgery, any clinically significant slit lamp or fundus abnormalities or IOP abnormalities were excluded. Also, patients with concurrent ocular diseases like glaucoma, cataract, retina diseases, or uveitis, or immunocompromised systemic diseases like diabetes or rheumatoid arthritis were excluded. Also, those with dominant strabismus were excluded. Also, patients who were previously participated in any drug or myopia clinical trials in last 3 months were excluded. And those patients who met the inclusion criteria only in one eye were also excluded. And the patients with previous usage or the current usage of RGP contact lenses or multifocal lenses were excluded. So this was the overall study design and the workflow. We screened the patients for their eligibility into the study and enrolled those who consented. The detailed clinical assessment was done in each visit. The visual acuity was assessed using logmar charts. Both dry and cycloplegic refraction was done in every visit using cyclopentolate eye drop. Anterior and posterior segment examination was done, and biometry was done using IOLmaster 700. Patients along with their parents were counseled one-on-one for what is myopia, its progression, the complications because of high myopia, why there is need for the intervention at that particular point of time, and what are the different options which are available for the myopia control. And then the patients were allocated in the treatment naive group. The parents were given an option of either starting on low dose atropine 0.01% at bedtime dose or Myocare glasses, and the parents chose which modality they want to consider. Again, in non-responders or non-satisfactory responders to night dosage of LDA, the patients and parents were given an option whether they want to increase the dosage to BD or add myocare lenses on top of continuation of HS dosage of atropine. Patients were followed up every 4 months and they were reassessed for their lifestyle modifications, vision, cycloplegic refraction, the condition of their frames and lens, the fit, and whether the glasses needs to be changed. And we are here at the interim results at the end of 1 year. The final results are expected at 2 years. The primary outcome variables were two. First, the percentage reduction in the axial length elongation, and second, the percentage reduction in the progression of spherical equivalent. Secondary outcome variables were adaptability, variability, and vision-related quality of life. This is a smiley questionnaire which was administered at 4 months follow-up and at the end of 1 year after prescribing the myopia glasses. But again, the scope and the interest of today's presentation, these results are beyond the scope, so I will not be addressing these in this presentation. Coming to the results, as you can see, all 4 groups showed female predilection, as you can see here. And interesting to see that in both group 2 and group 4, like females definitely have more myopia progression, we know that. But again, females had significantly more percentage of non-respond in the non-responder cohort, as you can see in group 2 and group 4 respectively. The mean age group was around 11.5 years in 1 to 3 groups and around 10.2 years in group 4. Coming to the results of spherical equivalent, the mean increase in the spherical equivalent at the start of the intervention for LDA HS group was 0.94 diopters, which was dropped down to 0.33 diopters at the end of 1 year, which shows the efficacy of around 64.67%. I want you to see at the third group next, where at the start of the intervention, the mean increase in the spherical equivalence was 0.89 diopters, which was reduced to 0.29 diopters, around 0.3 diopters at the end of 1 year, with the efficacy of 66.51%. Whereas in LDA BD group, the initial, at the start of intervention, it was 0.67, which was reduced to 0.39 diopters with the efficacy of around 40.50. And in combined group, it was around 0.7 diopters, which was reduced to 0.37 diopters at the end of 1 year with the efficacy of 45.70%. Similarly, when it comes to the axial length elongation, the efficacy to reduce the axial length elongation was around 61.2% in LDHS group, around 64.5% in myocare group, around 42% in LDA BD group, and 47.5% in combined group. Now, comparing the efficacy of different treatment modalities. So when we compared the LDHS to that of myocare glasses in the treatment naive group, both showed significant reduction in spherical equivalence progression and the reduction in the axial length growth. But the difference in both the modalities was not statistically significant. Whereas when we looked into the LDA BD group versus the combined therapy group, yes, the combined therapy did better in both reduction in form of reduction of axial length as well as the reduction in the spherical equivalence progression at the end of 1 year. Reviewing the literature in brief, myocare lenses have established their efficacy across different parts of the world. And even in India, the Arvind Group has published their 12 months results and shows the real world evidence for slowing myopia progression with the myocare spectacles. This is a recent study, which was a retrospective study published in IJSR, which compared the effectiveness of myocare lenses with low-dose atropine. They included the patients even with high myopia, around -10 diopters were also included. And they compared myocare with atropine with the single vision glasses and showed the significant reduction in both the groups, which was again similar efficacy-wise for both the group with no statistically significant, one better than the other. So both were equally efficacious, which is again similar to what we saw in our study. Coming to the combination therapy, as Mr. Nikesh explained in his presentation pretty well, we have good evidence by now for orthokeratology with atropine combined therapy. Moderate evidence with a handful of studies for DIMS, DIMS and that of atropine, DIMS with atropine, and limited evidence for halt lenses with atropine. And there are no studies till date which compared the Myocare lenses with atropine as a combined therapy. Dr. Jitendra published his observations on the effect of DIMS lenses in halting myopia progression in non-responders of 0.01% eye drops in IGO in 2024. And this aspect study was published recently in 2025, where they compared DIMS with low-dose atropine. But again, this study was not on those with non-response to low-dose atropine. They had a two separate cohort, one with single vision glasses and other with the defocus glasses on combination with 0.25% atropine. So what the current study adds, this is the first prospective study to compare the effectiveness of Myocare glasses with low-dose atropine for the direct head-to-head comparison of these treatment options. And the first study to compare the LDA BD dose to that of addition of optical treatment of any kind in non-satisfactory responders, which can help us in optimizing the regimens for non-responders. So I conclude with this that both bedtime dosage of low-dose atropine and Myocare glasses show significant reduction in myopia progression with the similar efficacy of around 65%. Patients who are non-responders to HS dosage of low-dose atropine can be given an option of BD dosage or a combination therapy, but definitely combination therapy works better than increasing the dosage to BD in those who are not responding to HS dosage. Thank you.
Thank you. Thank you so much, Dr. Ajinkya, for your excellent insights on this kind of combination therapy. So now can we have discussion or comments from expert panelists?
So, Dr. Ajinkya, when did you start the study? I missed the year, the duration you started this?
We started in June 2024.
Okay. Because in my personal experience, this was the first myopia control glasses I started in my private practice. But I did not see much of control with the Zeiss Myopia lenses. And I think they did some modification in the end of 2023.
Yes.
Post which I think there has been a better control. But then
no, they have come up with two designs. One with Myocare S, which is for relatively elder age group, and Myocare for younger than 10 years age group, where the central zone is smaller for the kids who are younger and very tight progression zones in the periphery for the fast progressors, which are relatively younger.
Yeah. So when you started before that, you used this or that is the
so
only
we prescribed Myocare S for patients who are about 10 years of age, and Myocare glasses to those who are less than 10 years of age.
Okay. No, I was just asking, like you have an experience before 2024 for these glasses or post that?
No, we had not used it before. Yeah.
Because personally I didn't, and I just started advising more of DIMS and halt classes, which is the Zeiss Myocare.
Earlier, we also had experience only with DIMS.
DIMS.
Yeah.
Yeah. So no, but of late, 2 or 3 of my patients have got Zeiss Myocare from outside, like by themselves. They opted for that, and I didn't see much of progression. So I think they have changed the design, and because of which there is a better control now.
Correct.
No, I think this is quite, it's interesting to see, and also, the effectiveness. And so there are different forms of combination therapies, as we are now seeing, which can be combined to look in, to give to give the right kind of control that we need. So yeah, this is a good one, Ajit.
Thank you.
I think what we can see from your, from the results was that the children who were progressing faster had a better effect. That is what is the around the world also they have observed that children who are progressing faster, it is the results are much better, and that is probably the reason why everybody now tends to see the results in terms of numbers rather than in percentages, because the percentages can be really misleading. So
yes.
Dr. Jinka, did you find some effect of the age in the outcomes?
So we tried to recruit from, like, the age group was 6 to 15 years, but unfortunately, we have very few patients who are less than 10. So the median age was around 11, 11.2, 11.4. The median age was 12 for all 4 groups. So we could not analyze like younger age to the adolescent age group. But yeah, it would be interesting to know with a larger sample size. Yeah, very valid thing to look into.
Sorry, I was on mute. The reason for asking that question was the Myocare themselves came and said, Myocare is for one group, but then Myocare S is typically for somebody who is younger than 10 years. So therefore, if there is any differences in the outcome.
Correct. So it will be interesting to know that, because there are different designs for both the groups, younger than 10 years and more than 10 years. So,
and you used only one design, right?
No, for those who were elder than 10 years, we prescribed Myocare S glasses. Those who are younger, we prescribed Myocare as per the recommendation from the Zeiss group.
But won't that add a confounding variable itself? I mean, you're right about the age and the indication, and ethically, you should be using Myocare S for younger age group. But when you are doing a study, it would be hard to know. I mean, if you
so it will be correct to more appropriate to look into the results age-wise for the design-wise.
But wonderful study. I mean, atropine twice a day has hardly been studied, at least in our country.
Yeah. Thank you.
Mihir, if you have any comments. You're muted, Mihir.
Hi, am I audible? Yes.
Yes.
Yeah, sure. Certainly, I would congratulate. This is a very useful study, and it was required because in the randomized controlled manner, twice a day, and the combination therapy has not been compared. Of course,
just to correct, sir, it was non-randomized. We gave the option for the parents to choose. It was non-randomized.
Okay, sure. So of course, the randomization can take off all the confounder and can convert your level B study to a evidence level 1 study.
Yeah.
But whatever preliminary results that you are showing, they are quite surprising to me. We do find patients having a very good response with twice a day low-dose atropine. And Rohit Saxena will soon publish his results. Yeah.
Okay.
I feel Stellest is giving us better results than Myocare. So in between, for 1 full year, we exclusively used Myocare, and then results were not very satisfactory. So we converted into more frequent use of HALTs.
And again, I think we have recently got a publication from Arvind Group where they compared HALT with DIMS with CARE technology. And in that as well, I think the DIMS perform better.
In our experience, also DIMS perform better than other myopia control glasses. There's very marginal difference, not so significant, but it's there.
But now that we're speaking about the spectacle options, there are multiple other copies right now available. We spoke about DIMS, Stellest, and the Myocare. Any experience from anybody on, Atropine combined with any other, I would use the word generic mode of spectacle?
So I have used what is called as Transvision Care's Myosol lenses, myopia solution lenses, which is available from Bangalore. It's basically an Italian company, and we have found its efficacy to be significantly lower than the Stellest lenses. It's around 30 to 35% is what we found in our first 10 patients. Nowadays, we are not using it as a routine. Only when the cylindrical powers are more than 4 or the spherical equivalent is going more than 10, where the conventional defocus lenses are not available. In such situation, we are giving them the option because they are able to make spectacle lenses called myosol at a higher spherical equivalent as well as for a higher amount of magnitude of astigmatism. It's less efficacious.
What technology they use, sir?
So it's a wavefront technology wherein you have the defocus created using the ray tracing interference in the periphery. It's a unique technology. Transvision Care is the name.
Transmission care. Okay.
We also, because you said Myosol, we have Myoslow also, which is from Titan. Titan has got the Myoslow.
That Myoslow is actually the previous version of HALT. It is similar to SALT, slightly aspheric lenslet therapy. So they are actually very close to progressive add-on lenses, the Titan ones. There is another company by the name of Myokiddo that is also available for customized. I mean, if you have power more than 12 or 13, where you still want to make you want a similar design. But the problem is that they have a central zone which is laser etched. So you can actually see the central zone. We have used them only for a couple of patients because they're also similarly expensive. So not much experience.
Again, MyoFocus is from Ben Franklin. So again, no experience.
Yeah.
Thank you.
All these lenses have similar, or if I may say, same principle of counteracting the defocus in the periphery. But I think we're only waiting for the evidence or scientific evidence to say which one works better than the other.
I think all these are like biosimilars of we have for anti-VEGF. Later we need to study them if they were better and if they are cheaper, if those could be the options.
Thank you everyone for the useful comments and discussions. So now I would like to call upon Dr. Mayur Kothari sir, Senior Pediatric Ophthalmologist and Squint Specialist from Mehta Eye Clinic, Mumbai. So he'll be talking on rebound myopia. So current understanding. Over to you, sir.
Thank you. So Dr. Jitendra, special thanks to you for getting me into this webinar. And I thank All India Ophthalmic Society for giving me the opportunity to talk about this particular topic. In this presentation, I want to start with the disclaimer that the data is not completely analyzed as yet. It's a part of thesis. It's a randomized control trial of 2 of my residents who are doing DNB in ophthalmology, wherein they are looking at the sudden versus slow as well as very slow taper. That's a pace of taper is being evaluated to figure out the rebound myopia with atropine cessation. We also has initiated the randomized control trial on effect of HALT on reducing the incidence and magnitude of rebound myopia, as well as independently how much rebound myopia takes place with HALT when used alone. And we have recently completed a global survey of knowledge, attitude, and practice of pediatric ophthalmologists regarding rebound myopia. So the current presentation is full of the data available from these studies, as well as the previous ATOM study, as well as LAMP study, and a few other studies. Now coming to what can be called as rebound myopia, and the answer should be any acceleration of myopia progression once you stop active intervention, which could be atropine, which could be HALT, combination, soft contact lenses, or ortho-K. And that can be defined as anything more than what you expect for that particular age of the patient. So it is measured in terms of spherical equivalent refraction or axial length. This was the definition given in atom studies, where more than or equal to 0.5 diopter per year increase of SER or 0.2 millimeter per year or more of increase in axial length could be called rebound myopia if it has happened within the first year of cessation of the intervention. Now, it is very important for us to take home this point that spherical equivalent refraction is definitely important as far as the measurement and monitoring of myopic patients is concerned, because it is easily measured. Every clinic can measure it, and parents are very sensitive to this information. If somebody's power has increased, the child's power has increased from -4 to -4.5, it is quite alarming for the parents. But higher magnitude of axial length increase from say 24 millimeter to 24.2 millimeter in the same period of time, though it is actually more alarming, parents are less sensitive to this information. So SER increase is definitely more convincing, especially for the parents, but axial length is more objective. It is quite a lot more sensitive. It has significantly lower variance, and it's in significant number of patients. It gives a lead around 2 to 6 weeks prior to an increase in SER. We are able to pick up. The cons of reporting only through SER is it has poor sensitivity, and also corneal changes like astigmatic changes will be manifest as a progression. Rather, in axial length evaluation, it will be purely the axial elongation. In our studies, what we found was if you rely only on SER, then 30% patients will be missed from the diagnosis of rebound myopia. And same way, if you measure only axial length and rely on definition of axial length progression, then 30% patients myopia progression or rebound myopia will be missed. So it is always good to measure both and have the definition which includes both of them. Now, coming to rebound myopia, incidence is present not just with atropine, but it is also seen with ortho K or even combination of atropine with ortho K. In general, soft contact lenses or defocus spectacle lenses, the rebound myopia menace is significantly less common or lower magnitude is being reported. So it could happen with anything. However, the drug withdrawal has the highest, atropine withdrawal has the highest incidence as well as magnitude. And it's been very well known that higher the concentration, higher is the chance of getting rebound myopia and the magnitude of rebound myopia. And this is what actually became the game changer for ATOM2 study, and people adopted to 0.01% atropine, not just because it has less side effects, despite of having lower efficacy, because it had lower rebound, it became the first treatment of choice. And another nice thing about using 0.01% and then stopping later on, even if the rebound myopia takes place, the rebound progression is still lower than the control group progression. So those who were never treated with atropine versus those who were treated with atropine 0.01% and then suffered rebound myopia at a later date will still end up with lower myopia than a patient who has never been treated. In our preferred practice pattern study, we realized that a majority of pediatric ophthalmologists are unaware of the incidence of rebound myopia. Most of them felt that the incidence is less than 10%. So it is quite an underdiagnosed, underestimated abnormality when atropine is being withdrawn. Apart from the concentration of the drug used, it's the age also that matters. When you decide to withdraw the drug, if the child is less than 12 years of age, then there is a significantly high chances that the patient will suffer from rebound myopia. Not only there is a high incidence, also there is a significant magnitude. So in general, in our practices, and most pediatric eye surgeons, they tend to withdraw the drug only after 12 years of age. And even ATOM studies were designed to include the patients up to 12 years of age. Of course, rebound myopia is seen in patients who are in their teens and adults, but then the incidence as well as magnitude both tend to go down. These graphs come from Dr. Rohit Saxena's randomized control trial, where sudden stoppage of atropine drops versus slow stoppage of atropine drops was evaluated, and nearly 33% lesser SER or lesser axil length progression, both ways, was documented. So every third patient you can save from rebound myopia if you just simply make it taper rather than a sudden stoppage. In our study, what we found was whether the pace of taper is 3 months or 7 months. That means you do a slow taper versus a very slow taper. We don't find any significant difference. The pace of taper tends to stop making a sense after it is 3 months. And there is some biological plausibility and explanation behind this, which we will come to it in the later slides. But we didn't find pace of taper making a significant difference in the incidence or magnitude of rebound myopia. What we found quite interesting was in the group where we had an encouraged monitored daylight outdoor physical activities, we found there was a significant reduction. So 24 times higher odds of developing rebound myopia if patient was having less amount of outdoor daylight physical activity, and it is quite significant in terms of the amount of outdoor activity which is required to protect the child from rebound myopia. And through the ROC, the area under ROC curve, we've realized that the risk is significantly reduced if patient is spending around 120 minutes, 2 hours or so. Nearly 82% patients, the rebound risk reduced if patient was having a outdoor activity of around 2 hours or more. Even when you see retrospectively, 90% of patients who had rebound myopia had a low outdoor time, and 71% only had an outdoor time which was more. So outdoor activity in daylight significantly reduces rebound myopia. Now coming to the question of why does this happen, the muscarinic receptor upregulation theory is the most accepted theory, and some of the phenomena in rebound myopia can be explained through this theory, such as when it is a G protein bound receptor on the cell membrane of the inner nuclear layers of the retina, which tend to control the glycosaminoglycans as well as the choroidal blood supply. And when the atropine is used for a prolonged period of time, starting from 2 weeks onwards, there is a significant increase in the number of receptors presentation on the cytoplasmic membrane. And when you suddenly stop the drug, this increased number of receptors make the eye more receptive to the up signaling of the both choroidal vasculature will thin out, and the axil length will start increasing. So receptor supersensitivity tends to be the most acceptable hypothesis at this point of time for causation of rebound myopia. And how does this happen? Now, this is an interesting slide because we defined rebound myopia in two categories. First category is called as early rebound myopia. So once you stop the drug and you start seeing the patient within a few weeks itself, so starting from 2 weeks post cessation of the drug, up to over 2 to 3 months, you will find that there is a significant choroidal thinning that is taking place. You need a special type of OCT scan to take the measurement of the choroidal thickness. And the studies show that when you start atropine at different concentrations, there is a thickening that is taking place. And when you withdraw, there is an equivalent amount of thinning that takes place. So in first 2 to 3 months time, whatever progression of myopia takes place, which we would label as rebound myopia, which is classified according to us in early rebound myopia, could be partially reversible and could be explained primarily by the vascular changes which is taking place in the choroid of the patient's eye. While what happens after 3 months, which we would like to call as a long-term response, and this is a new term which we would probably propose in some time, called late rebound myopia, which is an irreversible situation where the progression has happened. Now, if you restart the drug, or in fact, sometimes when a virgin eye is being started on atropine, we used to find them having regression of myopia. We used to blame it that, oh, initially it may not have enough cycloplegia when we checked them, and it was the pseudomyopia which we included in the treatment. But now it seems it could be the rebound myopia of first type, which was reversible, either partly or fully. And when it happens after 3 months, it's not something which is going to be reversible. Coming to the next question, how early have we noticed rebound myopia? And as I just conveyed, we have had earliest occurrence of rebound myopia happening in first 6 weeks itself. And the peak was being seen between 2 and 3 months of time. Not only in the spherical equivalent refraction or just axial length, both we are saying, when both the changes were actually documented in our patients. And regression after restarting the drug is also seen in our studies. And after initial commencement, as I just told you, when we first time start the patient on atropine, sometimes we have noticed that they have a regression in their myopia SCR as well as on the axial length evaluation, which you can document in 6 weeks to 3 months time. So in conclusion, over here, prevention wise, it is best to start with the lower or the lowest possible effective dose, which is 0.01% at bedtime, or in some situations, maybe twice a day, or 0.05%. But anything more than 0.05% at the beginning itself could lead to a significant incidence as well as magnitude of rebound myopia later on. Also, once you start, it may be a good idea to use it for at least 2 to 3 years, or till 12 or 13 years of age of the patient, before you consider taper or sudden stoppage. Of course, sudden stoppage is not something which most pediatric eye surgeons nowadays prefer to do. It's always a gradual taper over 6 to 12 months time. We would say anything beyond 3 months to up to even 12 months, we don't find any significant difference. But then, yes, it has to be tapered beyond 3 months of time. A combined optical defocus therapy could also reduce the chances of rebound myopia, because one modality such as optical defocus, either through the ortho-K or HALT or soft contact lenses, will continue to work. In fact, ortho-K has a higher chance of having rebound myopia in comparison to an HALT, or even better, soft contact lenses. When you are going to start tapering the drug in patient who was already on atropine once at night, once you have achieved your 2 to 3 years of very good control, then doing a close monitoring through SCR as well as axial length evaluation is mandatory. In our preferred practice pattern survey, only 5% pediatric ophthalmologists felt that rebound myopia is inevitable. Most pediatric eye surgeons would feel that with appropriate interventions, you can actually not have rebound myopia in children. So you just need to be smart on how to withdraw the active intervention. Now, once atropine is withdrawn, or ortho-K is withdrawn, and if you notice that the patient has developed rebound myopia, then you need to reinstate the therapy. As far as atropine is concerned, it's a good idea to start with the strength lower than what you initially used. If you are using twice a day, or if you were using 0.05%, maybe a good idea to reinstate at a lower dose, because that is strongly related to how the repeat rebound myopia will take place. And along with that, add an optical defocus, DIMS or HALT or soft contact lenses, as is your preference, and monitor the axial length in such patients every 3 to 6 months. So that's all I know, or we know right now, about rebound myopia. It's a common phenomenon, especially after use of atropine, more so when it is a higher concentration. When the drug is being withdrawn at a lower age of the patient, or when use is shorter than 3 years, and when the patient is not having a significant outdoor daylight activity. So do encourage outdoor activity, do a slow taper, include an optical intervention along with the pharmacological intervention, and always try to encourage the outdoor daylight physical activity. Not just encourage, it may be prudent to do the monitoring through the logs, or using certain devices where you can monitor. And this patient should best be evaluated in at least every 3 months. I would suggest initially every 6 weeks may be a good idea, because early rebound myopia, you will be able to pick up anything between 6 weeks to 3 months itself. And if you reinstate the therapy, a lot of them are going to reverse back. So thank you very much for your attention. I'm open to the question.
Thank you, sir. It was a wonderful talk on rebound, even though it is very challenging to record the rebound phenomenon. So now panel is open for discussion. So one or two questions. We have Dr. Mona join with us. So before that, can we have one or two questions from the panelists?
I have one question, sir. So, how long is the maximum duration of atropine treatment do you recommend in children? I mean, like if you feel beyond which it has to be stopped, whether the treatment is working or not, it has to be tapered and stuff, like maximum time period.
So we have a minimum time period guideline available. Maximum timeline is actually, we don't have that answer. We have had to use atropine. Right now, we have around 11 patients, I wouldn't say children, who are using atropine even at 24 years of age. A lot of them are girls. They are not girls now anymore, they are ladies. But yeah, we have seen myopia progression happening even in later age. So we don't have an upper limit. In fact, I myself at age of 37, I had a sudden progression in axial length while doing a research fellowship somewhere. And I had to start the drug for some time. This was way back in 2010 when this atropine was not available. We used to mix it and make it, and it was personal communication with Audrey Chia that I started using for myself. But there is no upper limit as such. At any age when you are sure that there is axial elongation that it's taking place, and the patient is at a high risk of ending up in high myopia, it may be or axial length more than 26.5 millimeter is for us a cutoff. We don't want any patient to go beyond that axial length because it exponentially increases the risk of retinal complications, glaucoma, cataract, etc. At a later age. So no upper limit as such. Until whenever you need to use, you need to use.
I think one of the concerns that are also there is that there are a lot of times when people who are not even possibly progressing would be put on atropine right up front by sometimes by ophthalmologists. Sometimes it's available to get the drug off the from the pharmacies in India is not all that difficult. In those cases, do you anticipate that now if we stop them, though we know they're not progressors, that they're likely to show some rebound despite that?
Yeah, so whether the patient was progressing or not progressing, once you start the drug, the receptor changes are expected to take place. There will be some amount of hypersensitivity to acetylcholine whenever you are going to withdraw. And I would say even if patient did not require atropine and for some reason it was started, it may be prudent to consider that there is a possibility that these patients may develop myopia, and you treat them as a potential candidate for developing myopia in due course of time. So unless he is or she is hypermetropic, all emmetropic patients also, it may be a good idea to look at them within 3 months' time.
Would there be a small time limit as to this much amount of days they have put, and only then they can have hypersensitivity towards the receptors? I mean, any minimum time which they have used, like if early users have put only for 15 days and then we can stop.
So recently, one of our patients was seen by Audrey Chia, and we had a personal communication with her in Singapore. And she said if the atropine dose that you are using is very high, then the hypersensitivity takes place within 1 week itself. So it's like we are putting atropine nasal drops, and then after 1 week there is a tachyphylaxis, and the same amount of drug or same frequency may not have the same outcome. Same way, I think with topical atropine also, more the concentration earlier will be the hypersensitivity, and more severe will be the hypersensitivity. So anything beyond 1 week is what we feel, but the changes are noticed in 2 weeks time. The electron microscopic changes on the receptor level is seen after 2 weeks.
And I think something that stems from this question also is that supposing, we have patients who are already on atropine, and sometimes they would just leave it a month before they come to you just because they think they're coming and that, probably the course is done. Or many times you would prescribe it for a period of 6 months and they come to you in 8 months or something and they would say, oh, we thought it's only for that period. Do you think then one should restart it, or if there's not been much rebound, then just let it be? Or do you think what sort of is the stopgap or the area that you would say is safe for us to say that, okay, now you're fine?
Yeah, so in our studies, we have gone up to 13 months. Our study was lasting for 30 months from the day when you start withdrawing, or one group which was randomized to sudden cessation. So we looked at them over 13 months time, and for that amount of duration, that length of duration, we found significant number, more than 60% patients were actually getting into the definition of rebound myopia, either SER definition or axial length definition. Of course, if you are very strict and you say, oh, both has to take place before you call it rebound myopia, then around 30% to 40% patients will be missed. They will be presenting after 13 months. It may not be in first 13 months. So 1 year of follow-up is necessary before you declare that there is no rebound myopia happening now.
So,
Dr.
but
Nini,
later on, also after 1 year or so, have you seen any kind of cases where it has happened even after 1 year, the rebound thing?
So yeah, rebound can actually, I don't know whether we should call it as a rebound myopia, or it's just a
Fresh
natural
progression.
phenomenon. Rebound means we are trying to blame it on the previous drug. So if you really want to blame it on the drug, then it should be some time limit to it. Later, if there is any progression, then you can say, oh, now this person has some change in their lifestyle or some other abnormalities are there because of which there is a progression. But by definition, it has to take place within 1 year, and it has to be in a patient who is more than 5 years age, because up to 5 years of age, an axial elongation of more than 0.2 millimeter per year could be taken as normal. We don't have that data right now that 6 months age, what should be the axial length elongation that can be considered normal. At 1 year, what should be for an individual child considered normal. But anything beyond 5 years of age, and within 1 year, if you find that there is an increase of 0.5 diopter of SER or axial elongation of 0.2 millimeter or more, could be definition for rebound myopia. You can blame it on your stoppage of drug or any other treatment.
Dr. Kothari, I have a question. In relation to the hypersensitivity that you have indicated, how do you relate this to the optical mode of treatment strategies? Yes, the relativity, I think, is a little different compared to what we see with atropine. Site of action is different. But nevertheless, you still see some sort of rebound with the spectacle or contact lens options as well. I mean, we have seen that. So where do you now relate that? Now we're not talking about anti-muscarinic anymore.
Yeah, sure. So the final common pathway is still possibly the GAG formation as well as the dopamine regulation. And when you withdraw any of the active intervention, there is still a possibility that those things which were down-regulated will now not have any more inhibitory effect, or down-regulation will not be there. The normal factors are now again in play. But then it is not as dramatic as what you see with atropine, where you have actual, electron microscopic structures which you can blame it on.
Got it. The second question is, what's your usual treatment regime? You showed in the graph both the fast tapering versus slow tapering.
Yeah.
What's your best recommendation based on your experience?
So in our study, we had the regimen which is proposed by Dr. Rohit Saxena, where over 3 to 4 months you are tapering it off. So if it is every night, then you make it alternate night, then make it twice a week, then once a week, every month, and then stop. While in the second group, we had the protocol which was conveyed to us by Yair Murad from Israel. In one of the POSN meetings, we were discussing this, and then we found that even Audrey Chia was using similar kind of a protocol where you take off 1 day per week per month. So, for example, the patient comes, you tell him or her that you stop putting the drops on every Sunday. This last 3 years, you are now 14 years old. The progression has stopped now. So we do consider that there is a chance for us to slowly withdraw the drug. And in very slow withdrawal, you ask him to or her to stop on every Sunday. Then next month, stop on Saturdays also. Then after that month, consecutively on Fridays also. So like that, 1 day per week per month is withdrawn over 7 months time.
So
That's
Dr.
what we
Mihir,
want.
I have a case to discuss if we have time. So I have a 9-year-old child who came to me in 2022, and he was a regular progressor of more than 0.5 diopter every 6 months follow-up. So the first visit he had minus 1.75 diopter sphere. On 6 months follow-up, he had 2.25. That is the time I recorded his axil length, and the right eye was 24.89, left eye was 25.10. Yes, and I started and motivated and started on low dose atropine. Then June 2023, he was stable. The axil length was 24.90 and left eye 25.12. December 2023, again follow up. The axil length was 25 and 25.28 with a refractive error of minus 2.75. Yes, over all this period, this till December 2025, the axil length was within range, and then I started slowly tapering it off. Sorry, 2024, and then 1 year he was tapered off on low dose atropine, which I followed the protocol what Dr. Rohit Saxena had given. The parents, he's a very active football player. He does not have any screen time, and they don't have screens at home, and he's a football player. Then over that, to mitigate, the parents were very motivated. They wanted that while tapering it open, we will start wearing the DIMS glasses. So he's wearing DIMS glasses also. But now on follow-up last week, he came to me and he had a jump where he has a refractive error of minus 3.25 with 0.5 cylindrical also added to it, and the axil length jump is by 0.3. It is now 25.36 right eye, 25.64 in the left eye. So now how should we explain? They have mitigated the response by giving DIMS classes also. Still, the rebound has happened. What can be done next? So I have started again on low dose atropine. So how can we answer this? Like, in spite of mitigating the response by DIMS, still he had a progression.
Yeah, sure. So I would look at it as first of all the time duration from the taper that was started, and
Yeah.
when you diagnose as rebound, I feel it
Yeah.
was quite long, 6 months or something, right?
Yes, sir.
So the highest chances of this patient would have suffered the rebound was in first 6 weeks to 3 months itself. So
Okay.
an earlier evaluation of this patient's axil length and
So no,
SER
so
have picked
actually
probably.
I followed him up every 3 months when he was on tapering dose, but then the axil length I was doing at 6 months. Maybe I should have done earlier the axil length. Yeah.
Yeah. So
Okay.
in our last preferred practice pattern meet in Delhi,
Hmm.
Dr. Jitendra had a very strong opinion about not treating the patient without doing the scans.
Mm-hmm.
And
Yeah.
I also have similar feelings that a scan is necessary even after you have stopped or when you are trying to,
No, so
even
I
if the
was
axil
doing,
is.
but the 6 monthly, not 3 monthly.
Yeah.
That may be
So I
the
think doing A scans is, I think, very
every
important to pick
visit.
up such patients to avoid any surprises. And
Mm-hmm.
always believe that whenever you have an atropine withdrawal, whatever may be the age of the patient, whatever may be the lifestyle of the patient, there is a good potential for the progression to take place, whatever may be the age of the patient. Younger, of course, higher concentration, higher,
He's
less
13
outdoor.
now. So he's 13. We started tapering once he turned 12. And now my second question is, because he's already wearing DIMS glasses, like I've already given 0.01 atropine, but then that should be the thing, or they are asking, we don't want, should we stop wearing the DIMS glasses and just continue atropine till 15 years of age?
In general, the pediatric eye surgeons that we interviewed or surveyed rather, we found that combination therapy is better. Even we believe it
Better.
is a good idea to do the combination therapy
Continue both.
so that when you taper low dose atropine, you have something else to fall on to, which will continue to have some control and reduce rebound myopia. And when you get rid of the defocus lenses, the chances of rebound myopia will be relatively lower. I wouldn't say it will be abolished completely like soft contact lenses, but yeah, it will be lower. And yeah, you will still need to monitor them when you take them off both the therapies eventually for at least for 1 year.
Okay. Thank you.
Thank you, sir. Thank you, sir. In amount of time, we'll move on to next presentation by Dr. Mona. So,
I have her presentation. I will just share it.
yes, sir.
Oh, thank you.
Awesome.
Is it audible?
Of this webinar today, I'm Dr. Mona Al-Kabi. I'm a pharmacy consultant and partner in United Arab Emirates. So today I'm going to speak about the combined therapy in myopia control. In this agenda, I'm going to cover an overview of myopia control strategy, pharmacological approach, optical intervention, as well as combined therapy. Overview of myopia control strategy. Now we all know that myopia is becoming one of the most important public health challenges in pediatric ophthalmology. We are seeing a rapid global increase, particularly among school-age children and adolescents, with the highest prevalence in East Asia, but the rising is significantly worldwide. The current statistics suggest that in 2050, nearly half of the worldwide population may be myopic, and significant there will be a high risk of myopia sight-threatening complication. That make an early detection and the treatment is very important. Mechanism and goal of myopia management. So the main goal when we are treating myopia patient is to reduce the axial elongation because this is the key factor associated with future sight-threatening complication. We can achieve this through main two approach. First of all is optical intervention, which work by modifying the peripheral retinal defocus to slow the ocular growth. Second is pharmacological therapy, mainly low-dose atropine, which act through biomedical pathway affecting the scleral remodeling and retinal signaling. However, treatment success does not depend only on efficacy. Safety and long-term complication and the proper patient selection are essential to achieve the sustained myopia control in children. The current treatment and modality, pharmacological and optical, as I have mentioned earlier. Low-dose atropine remain one of the most effective treatment and option available, showing 50% reduction in myopia progression and good tolerability in children. For the optical side, we have different modalities such as the Dempsey glasses, orthokeratology, and the soft contact lens, which work by inducing peripheral myopic defocus to slow the axial growth. More recently, combined therapy, especially the low-dose atropine with the optical intervention, has shown promising synergetic effect and may provide better control in fast progressor. Most important is to know which patient is suitable for these combined therapy, which we will speak about it later. Why to consider combined therapy in patients? Now, monotherapy can slow the myopia progression, but in many cases, it does not completely stop the axial elongation, and this is our aim, to stop the axial elongation. This is because different treatments act through a different mechanism. Atropine, as I said, it's a biomedical pathway affecting the scleral remodeling, while the optical treatment modify the peripheral defocus or the corneal shape. We can combine these modalities together, by which we are targeting multiple pathways of the eye growth, and we can create more synergetic effect by reducing the axial elongation. So, what are the indications for starting combined therapy? The most important indication is the rapid progression despite the optimized monotherapy. Typically, patients who are increasing more than half a diameter per year, or axial elongation that is greater than 0.2 to 0.3 millimeter per year. We also escalate the treatment in very early onset myopia, especially under 8 years of age, or in children with a strong family history and high lifetime risk or pathological myopia. Other indications include high baseline myopia, fast axial growth on serial measurement, or particularly respond to a single modality, what we call it non-responder. Combination therapy is also useful in isometropic cases or when the progression is predominantly unilateral, whenever differential strategy may be required in such cases. The most study shows that combined therapy like ortho-K with low-dose atropine, typically between 0.01 to 0.05%, and several trials has shows additive effect in slowing the axial elongation, particularly in the first year of the treatment. For soft multifocal contact lens with atropine, the evidence is more mixed. When we look at the peripheral defocus lenses combined with atropine, the data remain limited and exclusive, with a small study showing variable results. There is also emerging evidence that the higher concentration than 0.04% atropine combined with the optical modality may provide stronger control, but we must also balance the risk of the side effects. In clinical practice, many of us use a stepwise approach. We start always with monotherapy, and we escalate to combined therapy when a progression continues. Initiation of combination therapy, it is essential to establish a reliable baseline. This includes accurate cycler fraction, axial length measurement, so we can document the true rate of a progression. We should also discuss with the family the expected benefit and the possible side effects, such as photophobia, near blurred with atropine, and the corneal risk associated with ortho-K, to ensure informed decision made together and good compliance as well. When combination is indicated, it is preferred to start it with evidence-based option, particularly ortho-K with low-dose atropine. Close follow-up is critical, typically every 3 to 6 months maximum. Monitoring refractive error, axial length, ocular surface status, binocular vision, and the treatment tolerance. Dose adjustment may be required to balance the efficacy and the tolerability as well. In practical, myopia control should follow a structured stepwise approach. We usually start with monotherapy based on the children's age and severity. Optical options such as ortho-K and multifocal contact lens for older children and low-dose atropine for younger patients. Reassessment is essential at least 6 to 12 months. If a progression remains significant, more than half a diopter per year, or axial elongation greater than 0.2-0.3, we should consider combined therapy. The preferred evidence-based combination is ortho-K with low-dose atropine for better axial control. Other combination may consider in selected case depend on the response and patient preference. If a progression continues despite the combination therapy, we escalate the treatment, adjust concentration, we switch modality, or repair rapid progression to a tertiary center. Safety and follow-up are critical when we using combined therapy. With atropine, the most side effects are photophobia and near blurred vision, which are dose dependent. Therefore, we should always have a great discussion with the family and consider a photochromatic lens whenever we are prescribing the lens for these children. For ortho-K, the main concern is the myopia keratitis. So strict lens hygiene, proper fitting, and careful patient selection are very essential in these cases. We should also monitor for corneal staining and ocular surface changes. With soft contact lens, compliance and lens can remain key, and the efficacy depends on the lens design and added power. Most important, regular axial lens monitoring is very necessary to assess the treatment response to a documented outcome when combined therapy is used. Although combination therapy is promising, there are still important gaps in the evidence. We do not yet have the clear data on the optical atropine concentration and duration when used with different optical modality, and most studies have focused on 0.01% with relatively small size samples. It is also not fully established which patient subgroup benefit the most, particularly in terms of age, baseline, refractive error, and rate of progression. Long-term safety, as well as the risk of rebound after stopping combination therapy, require further studies. Finally, there is a lack of head-to-head trial comparing different combination strategies. As I have said, recent study evaluation has shown that combination low dose with DIMS lens have shown encouraging results. Randomized trial demonstrate that this combination can reduce myopia progression by up to 70% compared to control, indication strong efficacy. More important, the combination appeared to slow the axial length more than either atropine or the glasses alone. In terms of safety, the side effects remain manageable and similar to those seen with each modality individuality, which supported use in a clinical practical despite the current limitation of long-term data. For clinical implementation, we follow a structural protocol. First, baseline assessment should include, as I said, cycloplegic refraction and axial length, measurement to establish the strategic point and documentation progress. Treatment is then initiated with 9 low-dose atropine combined with full-time dipstick glasses of inappropriate candidate. Follow-up show-up schedule every 3 to 6 months to assess refractive change, axial length, treatment tolerance, and compliance. And to give practical to have a flow chart, a stepwise approach to combine therapy in a clinical practice. We begin with a comprehensive initial assessment, including refractive error, axial length, risk factor, and the rate of progression. Based on these findings, we select the appropriate therapy and dosing according to the children's age, severity, and previous response. Regular monitoring allows us to evaluate the treatment efficacy, detect side effects early, and assess compliance. If the response is adequate, we continue to optimize therapy. If a progression persists, we modify the treatment either by adjusting atropine concentration, change the optical modality, or escalate to combined therapy. Key criteria for reassessment help guide when to maintain, modify, or discontinue the treatment to achieve optimal outcome. In conclusion, combined low-dose atropine with DIMS lens offer a promising evidence-based strategy for myopia control in children by targeting complementary mechanism, pharmacological modulation, and peripheral optical defocus. This approach can enhance efficacy beyond monotherapy. Current clinical studies supported safety and efficacy, particularly in fast progressor and high-risk patients. However, careful patient selection, proper consultation, and regular axial length monitoring are essential to achieve optimal outcome. A structured stepwise treatment protocol allows us to individualize therapy and integrate combination treatment safely in a clinical practical.
Thank you. Thank you, sir. It was a recorded version.
Yeah, it was recorded by Dr. Muna from UAE. She has, I think she has joined, but yeah, she's there. So we can discuss if we want to discuss this particular.
I have one question to all the panelists. And does anyone have taken vitamin D3 into account when doing a myopia workup or following any treatment guidelines? Do you have any experience with that?
I think me and Pawan, we both were discussing the same thing yesterday. There was a meeting on myopia late. I think yesterday night we had a discussion on what vitamin D can do. At this point of time, what I do is I know that vitamin D doesn't have much of a role. If you take bulk of people in India, because we sit indoors, most of them will have vitamin D deficiency. And it is just the fact that, most of the kids will have vitamin D deficiency. Even the accommodative esotropes or high hypermetropes will have vitamin D deficiency. Nevertheless, there is nothing wrong in, treating vitamin D deficiency, just that we should not be thinking that this would help in myopia progression control.
It's just like another indication of lifestyle modification. That's it. So less exposure, less vitamin
More
D.
of a side effect of lifestyle more of a side effect of not
Yeah,
sitting outdoors
yes,
rather than
exactly.
other way around.
Yes, yes.
I think the research evidence is also mixed, does not really go in one direction to say any protective effect. So, yeah.
There's a
And-
link in the chat box with regards to the questions for the certification. So those who have registered for this particular certification course can take up that questionnaire, and they will have to answer the questions to get the certificate for this particular certification program. And thank you so much for joining us, Dr. Swati, Dr. Pawan, Nikesh, Dr. Rajesh, Rashina, Dr. Digvijay, and Dr. Janani for moderating the whole session. Dr. Tejaswini could not. I mean, she had to go. So thank you so much, everybody. Nikesh, thank you for the wonderful presentation. Azinka, I think, has left because our interest in myopia sort of exceeded the time limit. So thank you so much, everybody. And if there are any other concluding remarks, please go ahead. Thank you, everybody.
Thank you. Thank you, Dr.
Thank you. Thank you.
It was wonderful.
Thanks, Dr. Jasani. Thank you.
Thank you, everybody.
Thank you.
Thank you so much, sir. Yeah.